we are here with the fourth episode of the second season of series on controversies and consensus in orthopedics, what we need to know. As you know, this series is being conducted bi-monthly every Wednesday evening with an interesting case presentation followed by discussion in each subspecialty of orthopedics. This season is dedicated to the young orthopedic surgeons having interest in each subspecialty of orthopedics with the goal of uniting skill with mastery, where the presentation is being moderated by an expert in that field. This platform is not only aimed at helping the young orthopedic surgeons to present their case and strengthen their communication skills, but also to reach to a broader and more diverse audience through our OrthoTV channel, thereby increasing their visibility and exposure. This program is conducted under the chairmanship of Professor Mohanty sir and Secretary Dr. Ashish Phadnis, Dr. Swapnil, Keny, and myself, Dr. Deepak Gautam. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at St. GS Medical College and KEM Hospital, Mumbai. He is also an honorary consultant to Jaslok, Nanavati, and Sushrusha Hospital. He is the past president of Bombay Orthopedic Society and he is also an academician and a researcher. Today, we have three brilliant young orthopedic surgeons, one each in arthroplasty, sports medicine, and tumor, with an expert panel including Dr. Arun, Kannan, Dr. Ravi, Teja, and Dr. Jagandeep Singh. I would like to call upon Professor Mohanty sir to introduce our presenter and proceed with this session. Dr. Mohanty sir, all to you now.
Thank you. Thank you, Deepak. Good evening, dear friends, and welcome to the fourth episode of the second session of Controversies and Consensus. And especially I thank Deepak for taking all the interest in organizing this event, contacting all the speakers as well as the mentors. And greetings from Mumbai, with the monsoon hitting the Mumbai today. So the temperature has come down a little bit, and with all these political, discussions in the air and all the heated discussions, let us start our session. So today's session is devoted to arthroscopy, arthroplasty, and oncology, musculoskeletal oncology. So first, it will be devoted to arthroscopy. Let me share my screen. So our first presenter related to arthroscopy is Dr. Pinaki Das. Dr. Pinaki Das is after his MS in orthopedics, is working as assistant professor at Institute of Medical Sciences, SAM 2, Bhubaneswar. He has completed his fellowship in arthroscopy and arthroplasty. And his presentation on arthroscopy will be moderated by mentor Dr. Ravi Teja Rudraraju. And he is a consultant knee and sports medicine surgeon in Apollo Hospital, Jubilee Hills, Hyderabad. His specialty of practice, knee and robotic knee replacement, sports knee injuries, knee preservation surgery, osteotomies around knee, robotic partial and total knee arthroplasty. He has done, enormous number of fellowships in Australia, United States, as well as in South Korea. And he was a clinical fellow in knee surgery at Royal North Shore Hospital and Royal Prince Alfred Hospital in University of Sydney, Avenue Hospital, Ramsay Health Care, Malabar Orthopedic Clinic, Windsor, Melbourne, Australia, and Gissinger Clinic, Musculoskeletal Institute, Danville, US, Cleveland Clinic Fellow, Florida, Clinical Fellow in Revision Hip and Knee, Dungton Sacred Heart Hospital, Halim University in South Korea. Welcome, Dr. Ravi, and welcome, Dr. Pinaki. And thank you,
Mohanty sir.
Thank you for devoting time. And now I'll stop share and welcome Pinaki to share his screen and present his case.
Thank you, sir. Good evening, everybody. I am Dr. Pinaki, presently working as assistant professor at Institute of Medical Sciences and SAM 2, Bhubaneswar. Today, I am going to present a case, a very interesting case on medial patellofemoral ligament reconstruction, an uncommon solution for a common problem. Now, coming on to medial patellofemoral ligament nitty-gritty. It is the constituent of the second layer as described by Warren and Marshall. It's a fan-shaped structure. The insertion on the femoral side is around 10.6 millimeter proximal and 8.8 millimeter posterior to the medial epicondyle. And on the patella, it's on the upper and medial portion. It's the major medial soft tissue restraint that prevents the lateral displacement of patella. It contributes almost around 53%. The critical force of dislocation is around 208 Newton of force at 30 degree of knee flexion. This is an image I have taken from the second edition of Noise Knee Disorders that shows the attachment and the shape of MPFL on the patella and the femoral condyle. Now coming on to the case per se, we had a 33-year-old female homemaker. She had around 5 episodes of left patellar dislocation over a period of 3 years. On examination, the Fairbanks apprehension test was positive. The J sign was positive, and she had a increased Q angle. These are some of the preoperative X-rays and the clinical photos that I have to share with you. Preoperative evaluation was done by X-ray and CT scan as well as MRI imaging. The insult solvity index came out to be around 1.1, which is almost around the normal limit. Trochlear depth was found to be around 4.6 millimeter. The positive finding was that of the TT-TG ratio on CT scan that came around almost 21 millimeter, which is way above the normal limit of 15 millimeter. And the lateral trochlear inclination angle was found to be 24 degrees. So the principle of treatment is to restore the functionality of the medial patellofemoral ligament, either by a simple reconstruction or in addition to other procedures. It might be bony or soft tissue, like tibial tuberosity transfer in the distal part or lateral release in the proximal realignment. So we planned a combined procedure of MPFL reconstruction and tibial tuberosity transfer because of the high TTTG ratio length. So now coming on to the intraoperative findings, the surface marking was done, as you can see on the right side of the screen. Then diagnostic scopy of the patellofemoral joint was done, which showed the patella on the lateral femoral condyle with minor arthritic changes like fraying. As you can see in this video, the patellar is almost on the lateral femoral condyle and there is mild fraying. So next, anteromedial incision, like we do for ACL graft harvesting, it was done and semidendinosus graft was taken out. After which tibial tuberosity transfer was done utilizing the same incision, extending around 1 centimeter proximally and distal. The tibial tuberosity was cut with the help of an oscillating saw, both vertically and horizontally. And after taking out the tibial tuberosity, it was distalized and medialized and fixed with two 4 mm cortical lag screw in a divergent fashion. After that, drilling of half-length tunnels through the patella was done with a medial parapatellar incision. The drilling was done on the upper part with a gap of 1.5 centimeter between the two points, and 4 millimeter cortex drill bit was used, which was drilled only halfway. This halfway was done so as not to increase the stress and decrease the chances of patella fracture. After the drilling of patella, the graft was passed through the patella and was tied with bonds on the lateral side. After this, the Scottle's point was identified on the lateral fluoroscopic images. As you can see in the photos, this is the photo after the fixation of tibial tuberosity with the lag screws and the drilling of patella is taking place. So the Scottle's point, it's determined by the imaginary lines one line passes through the posterior femoral cortex. The orange line marks transition of curve of posterior femoral condyle and is perpendicular to the blue line. Red line is at the posterior aspect of Blumenset line. So this scrotal point is a bit anterior to the intersections of this line. On the right of my screen, this is the real fluoroscopic images that we have taken during our surgical procedure. So after the identification of Scottel's point, guide wire was passed and drilling was done with 6 millimeter drill bit according to the graft size. And then the graft was inserted from the patellar to patellar side under the U loop was taken on the second layer of the knee. And then it was fixed after tensioning at 30° of knee flexion with a cortical screw of size 8 by 30 millimeter. This is the final video of the stability of the patellofemoral joint after the completion of both the procedures. As you can see, the patella is not subluxed laterally anymore, and its patellar tracking is in the normal limits. And this is the X-ray that we have got after the post-op, showing the fixation of tibial tuberosity by the lag screws. The rehabilitation protocol that we followed was the knee ROM was started as soon as the pain subsided. That was around 3 to 4 days post-operatively. Weight bearing was started at 2 weeks post-procedure. Gradual resumption of normal activities was done over a period of 12 weeks. And the post-op protocol, the rehabilitation period was uneventful. So my take-home message will be preoperative assessment to determine patient-specific contributing factors should be there. Array of treatment modalities is present in the literature for MPFL reconstruction. So surgical plans should be formulated, catering to the individual patients after a proper planning. This procedure, that is the transverse patellar double tunnel technique, it helps in minimizing graft impingement without increasing the risk of patellar fracture, as it is more anatomical and like the normal anatomy of MPFL, fanning out over the patella and the femoral condyle. Thank you.
Thank you, Pinaki. That was an excellent, case. Do you have a pre-operative video to show the patellar tracking? How is it tracking?
Actually, sir, I don't have the good quality of
Okay.
video. That's why I couldn't put it in the slide. I was searching
Okay.
for it, but the quality is not so good.
Okay. And pre-operative, any X-ray skyline views or something like that? Did you?
Preoperative, I had a AP and lateral view.
Okay.
Skyline
Okay.
view, sir, I don't have it the presentation right now, sir.
Okay. Okay. Yeah.
So, Pinaki, that was a great presentation. I think very well included most of the required information that any surgeon needs to plan for doing a MPFL reconstruction with TTO. So, one of the questions I had is, did you kind of look for any femoral introversion or anteversion of femur when during the examination? Is what I wanted to ask first.
Sir, clinically we tested for the excessive femoral anteversion by Craig test. The Craig test was negative, sir. We didn't go for further investigation for that, sir.
Okay, super. And during the planning, did you consider MPFL alone versus MPFL plus TTO? And what was your justification to go with TTO? Because of late, some of the studies that have come out recently indicates that MPFL reconstruction alone can also bring out equally good outcomes, in terms of doing the MPFL reconstruction plus TTO. Because TTO, as such, it is a bit of extra effort to, counsel the patients, and obviously up to your rehab changes and all those things. So, what is your take on that?
So my take on like planning for the TTO with the MPFL was due to the increased Q angle of the patient and so the grossly increased TTTG ratio. It was like almost 21 millimeter. So that's why the distal realignment procedures were planned along with MPFL. Otherwise, sir, only MPFL can also do the job.
Okay. And while doing the MPFL reconstruction, usually kind of, people go with parallel tunnel technique. And did you think of kind of an, a button that can, also be utilized to reverse tension the graft, in extension or 30-degree flexion once you fix the patella side with the anchors. So, like in terms of doing the technique, do you think screw versus button, which one do you kind of prefer doing it?
Yes, definitely the buttons are like more preferable. But due to our constraints of the setup and we try to do it with the bicortical screws, sir.
Yeah. One thing I just wanted to bring up is that I was just going through the recent literature before just joining the discussion today. Is that I think it is also very important to understand the age of the patient before taking inferences for Caton shams or patella alta and other things, because what recent studies show that younger pediatric age group have higher ratios compared to the older people, and one should not be deceived to take decisions on doing a TTO and other things when it comes to a younger population, or particularly at the age of 15 or less than 15 patients. So one of the points I got to know today. And Sir Mohanty sir, would like to ask you this question. Do you routinely scope all your cases before doing MPFL reconstruction, or can we straight away go to MPFL reconstruction in planning these cases?
I don't do scopies actually. I do only arthroplasties. But
Yeah.
other people who do scopies, they can, Arun, do you do scopies also? You have to
Because,
unmute yourself. You have to unmute
yeah.
yourself, Arun. Yeah.
So, yeah, I do MPFL reconstruction, sir, unless there is, if I feel there is a lateral release to be done or an osteochondral fragment that needs to be addressed, then I would do a scope, but not routinely for all cases.
Yeah. So something, thanks Dr. Arun for bringing that, because something I was taught in Sydney with David Parker and Brett Fitch is that you have to scope all the MPFL cases. But when I returned to India and started my practice, like most of the surgeons just directly do the MPFL reconstruction than doing the scope. I think there is no justification to do a scope versus not doing a scope. I think the only logic is to kind of think about osteochondral fragment if there is any, to kind of address it. But yeah, just wanted to have your opinion on that, because it has got money implications as well, because in corporate hospitals, obviously they charge for again scope and other things.
And what is, Ravi, what is your indication for doing a TTO then? Do you do TTO or you don't do at all?
I do TTO, sir, but my threshold is very higher in terms of doing it, because if it is definitely more than 20, then I would definitely start thinking about it. But increased Q angle and also antiversion, also patella alta, if I have to bring down the tuberosity, there should be at least 2+ factors that should convince me to do TTO. If it is just around 20, I would still kind of try to avoid it and just go with an MPFL reconstruction, because what usually happens with the reconstructing MPFL is that the vector is always goes downward. So inherently, when you do an MPFL reconstruction, you're trying to bring down the patella, which is reducing the patella alta, and probably we might get away with it. And studies have also shown that the outcomes are not inferior when you go with MPFL reconstruction alone versus MPFL with TTO.
Okay. So there are two indications that if it is more than 20, if the Q angle is more than 20, and if there is patella alta, so you prefer to do a TTO along with this. Okay.
Yes.
There are two important points. Good that you have pointed it out. And what is the post-operative rehabilitation after doing a TTO, Pinaki? Do you immobilize this, or you don't immobilize with some kind of...
Mobilization can be done as soon as the pain subsides, the pain is bearable for the patient, because we don't want to restrict the ROM of the joint. Weight bearings can be taken as with a very good precautions. we allowed weight bearing for the patients, partial weight bearing around 2 weeks and full weight bearing around 4 weeks in this
Okay.
particular case.
And when you start the knee flexion?
Sir, passive ROM was given at the third or fourth post-operative day, sir.
Okay, passive ROM, third and post-operative day. You fix the
One of the
TTO. Yeah.
please go ahead. Please go ahead, sir. Please go ahead.
No, TTO, and while doing arthroplasty in revision arthroplasty scenarios, now most of us we have given up, using screws for fixation. Now it is fixed with either with a T-bond or with fiber wires, the TTO fragment. What is it that you always use screws, or any take on that for Ravi, Arun?
Yeah,
What
yes,
is
sir.
it?
Yeah, I think screws are a fairly good bet, sir, because you don't have the stem coming in the way, you don't have a cement mantle coming in the way. So here screws are a safe bet, and these bones are not as osteoporotic as the revision knees that we have to do. So though there, because of osteoporosis, sometimes when putting in a screw, it can break. So those are the factors I think that led us away from screw to fiber wire fixation in revision scenarios. Here, I think still the screw holds this way.
Okay.
Also, Pinaki, I just wanted to bring out a point that when you fix the graft, obviously we do it at 30 degrees, but always very important to not it overstrain or over taut it, because that makes it more difficult the patella to kind of engage into the groove. So in extension, usually it should be kind of a bit tight, and in flexion it should be at 30 degrees, little loose when we kind of do lateral medial movement. So it should be always remember that it should not be completely taut while fixing the graft.
Right, good points. Any other questions related to this? Or we move ahead?
Move ahead to the second presentation.
Okay. So thank you, Pinaki. Could you stop sharing your screen?
Yes, thank you, sir.
And thank you, Dr. Ravi, for being there. And we would request that please be there for the other two cases as well. If
Yes.
you are not too much, busy in your practice,
No.
so that
No.
we'll have a, some discussion. So
Sure,
I'll
Manoj,
again.
sir. Thanks for the opportunity.
Now, let us move ahead with the next case. Now this will be related to arthroplasty. And we have Dr. Manoj Kandel from Nepal to present a case. He is a senior consultant orthopedic and arthroplasty surgeon at Bharatpur Hospital, Nepal. He has done fellowship in arthroplasty, arthroscopy, and sports medicine at Ludhiana Max Hospital, New Delhi, India, and participated in hip and knee arthroplasty workshops, AOPR workshop, Ranamata Orthopedic Conference, AO Spine, Primary Emergency Care, Hope course. So many courses he has completed, and he has 6 publications in peer-reviewed journals to his credit. Welcome, Dr. Manoj Kandel, and thank you for joining today.
Good evening, sir, respected sirs, and my dear all seniors.
Thank you. Just let me finish introducing Dr. Arun also. And the mentor today, Dr. Arun Kannan, who has done his MS Orthopaedics from All India Institute of Medical Sciences, New Delhi, is a consultant orthopedic surgeon at present at Apollo Main Hospital, Grims Road, Chennai. He is also adjunct faculty for the Department of Engineering Design from IIT, Chennai. He has completed his fellowship in hip and knee surgery from Virginia Commonwealth University, Richmond, and his areas of specialization is robotic hip and knee replacements, unicompartmental knee, direct anterior approach for the hip replacement, and revision joint replacement. Thank you, Arun, for joining today and devoting time for the academics.
Thank you, Arun, sir. Thanks for the opportunity.
Now, may I request now Dr. Manoj to share his screen and present his case.
Yes, sir. Good evening, sir. My all respected seniors. I myself, Dr. Manoj Kandel.
Share the presentation.
Here, I'm going to share my Today I am going to discuss and share my experience with total hip replacement in subsequent starting osteotomy in type 4 developmental dysplasia hip and some literature in support of this kind of procedure. Here, going through the background about the development, as we all know, type 4 developmental dysplasia hip is a severe deformity that results from the long-term dislocation of the femoral head, where there occur femoral head deformities, high hip center, or a short femoral neck with excessive anteversion, a narrow femoral canal, a hypoplastic true acetabulum with reduced depth and deficient superior bone stock, posteriorly located greater trochanter, and the variable degrees of the varieties of the soft tissue contracture, including the neurovascular contracture also. Here, the patient about which I am going to present is 34-year-old lady. Her parent noticed short right lower limb and limping at the age of 4 years. She completed her childhood, adolescent period, and when she became the age of 36, and she started to feel pain and shortening with severe limping in her right lower limb, which is so much disabling that she couldn't manage it. The pain couldn't manage with ordinary pain management, and there is lower back ache also, and the issue with limping and disability. When she presented to our clinic, we go through all her clinical history, developmental milestone history, thorough clinical examination, and there was equina short limb gait with painful terminal movement. Limb discrepancy was 5 centimeters. That was supraacute trochanteric. There is no any previous history of any swelling, any scar mark, any sinuses, and Harris score was 48. And we asked her to go to the X-ray of the both hip. By X-ray, we see clearly there is very high dislocation of the femoral head on the right side, and the condition is all that I have already mentioned and described in the previous slide. I requested her to do CT scan. The CT scan was missed, and the CT came with this MRI. We can see the deformed head and elongated capsule in all of the soft tissue contracture status. And with the X-ray picture, we can clearly describe this is a type 4 or arthrophilacteritis type 3 type of the developmental dysplasia. This is the severe type. Since our hospital, government hospital, and such is presenting late, such kind of deformity is a common trend in our society. We do not have any special option here, and we have not gone through this kind of arthroplasty procedure also. And we discussed among our team, and what to do. We do not know, and whether to leave or whether go for arthrodesis or whether to do arthroplasty. And after doing all clinical, all radiological, and all investigation or discussion among us, we decided to go for arthroplasty. And we choose the posterolateral approach. We did the thorough adductor tenotomy, iliopsoas release, gluteal maximus tendon release, all external rotator, piriformis piriformis tendon release, and intramuscular septum release. And after this, we released the whole elongated capsule, and we did the total capsulectomy so as to reach to the area of the acetabulum. After doing removing the all scar marks, soft tissue, and the contracted tissue, fibrous tissue, there was some degree of a variable degree of the infected tissue also. We sent for histopathology, but it was negative. And we did thorough reaming, and in order to do the reaming at the proper site, so as to prevent the area marking of true pelvis and whole pelvis, we choose the Shyam guidance. we did reaming. Under the same guidance, we put the cup, and after doing this, but the femoral head was too high, we couldn't reduce the hip in its original native side. After, while going through the whole literature, we couldn't put the acetabular cup at the false or false acetabulum because it was deficient in bone stock in superior lateral and anterior also, and there was good bone stock in the true acetabulum, and which was the native acetabulum area, but the femur was very much high. So by any means, circumferential soft tissue release, we couldn't get any option. Hence we decided to do subtrochanteric osteotomy. We did subtrochanteric osteotomy, and in order to prevent the breakage of the femur while doing rasping and osteotomy, we protected this proximal portion of the femur with the cable wire. Then we put the femoral stem, and that is stabilized with the plate fixation, and we continue the cable wire as it is. We do the transverse subtrochanteric osteotomy. This is how we did. This is the immediate X-ray at the time of operation. Is guidelines given by the Campbell, and while though not accuracy, Ranawat triangle also at the same place. After going through the radiology examination, this is the immediate post-op X-ray, and the 1 month follow-up. There is no any dislodgement of the bone. There is no any subsidence of the implant, and there is no any rotation. And though there are varieties of the subtrochanteric osteotomy like transverse, oblique, Z-shaped, chevron-shaped, each of there has one advantage and disadvantage. The main disadvantage of osteotomy is the risk of fracture and non-union. It has been stated in various literature. The transverse shortening osteotomy has a high rate of non-union and the rotational instability. But in this, after doing this has been completed almost 1.5 years. There is no any rotational stability. There is no any non-union. I will show the X-ray later on. In support of which there are various literature. In case of the where there is a false acetabulum is occur in the case of development discharge that has been set up in the early childhood, there is an elongation of the proximal portion of the femur. It has been described in the many literature. Hence, we have to go for the osteotomy by any means in order to reduce the hip in its native acetabulum. These are the literature that is in support of this transverse subtrochanteric osteotomy. Give the similar result like that of the chevron osteotomy in all other kinds of the osteotomy procedure. These are the literature in meta-analysis which give the support in support of our transverse osteotomy. In 1 year follow-up, there is complete union. There is no gap, no rotation, no implant subsidence, and head shapes are increased to 85. There is no length discrepancies. The patient when presented was like this, and patient when it is at the end of the 12 week, she is working, she is coming on wheelchair, she is walking without any support, and this is all about my case. But what controversy in their presentation case is I did the total hip replacement in the young lady, but we do not have the option of modular implant like S-room because it is not available in our setup. I did the subtrochanteric osteotomy, but I going through the subtrochanteric transverse type because it is easier one, and there is no any chance of rotational instability because I do not have any quadrangular type or any S-room type stem that prevent any rotation and dislodgement or subsidence implant. The cementless femoral stem is mostly preferred. I choose the coral type stem which has fully hydroxyapatite coated, which gives the added rotational stability to the implant. And the plate fixation is not mentioned in any literature till the date, but to secure the implant in its own place and to prevent any rotation. And I don't have any long stem. I want to maintain the rotation and the bone fixation with the simple DCP in order to prevent any rotation or any dislodgement or graft in implant. Here, which is proudly working without any problem and rotation and good healing at the osteotomy site. Thank you.
Thank you, Dr. Manoj. That was an excellent case and a very difficult case, crow type or dysplastic hip that you have managed successfully, showing a good outcome and union. So over to Arun for discussion, and in between also we'll discuss together. Yeah.
Yeah. Dr. Manoj Kandel, that was an excellent result for a very difficult case. Yeah, and I think you had to use kind of improvisations because of lack of implants in your place. I think this case, I think you've come out well, and just recent. I mean, apart from being able to reduce the hip, so even if you had managed to reduce the hip without doing a shortening osteotomy, I think you are not able to, and that's a good thing. The thing is, if you stretch the hip out without doing an osteotomy this much, you are more likely to lose the sciatic nerve when you stretch it out that much. So that is one of the reasons that we, I think, have to do the subtrochanteric osteotomies in type 4 dysplasia. Not only for being able to reduce the hip, but also to protect the sciatic nerve. If you stretch it more than 2.5 centimeters, then you're likely to stretch out the sciatic nerve. So that is one point that you have to keep in mind. So in this case, definitely needed the subtrochanteric osteotomy. Even if you did more release, bring it down, you won't be able to release the sciatic nerve, it will get stretched out. So that is one thing that you have to keep in mind. And secondly, I think here you didn't have to have an SRAM type implant, but the other option that you could have employed, I don't know if it's available in Nepal, is use a diaphyseal fixation stem, and you can use a plate as you've done for rotational stability between the proximal and distal fragments. Here, the corail doesn't have a diaphyseal fixation, so I mean, it could have gone a little bit either way, but good for you that it has stayed and it has not subsided. It has held on to its metaphyseal fixation. So those are 2 points that I think that have to be kept in mind. One is sciatic nerve, and second is being able to have a diaphyseal fixation in these cases when you've done an osteotomy.
Is Wagner type of stem is not available?
Not, sir.
Wagner, so it's very difficult to get there. And
Okay.
he works, I think he works out of Kathmandu. It's not in, it's in the outer
Bharatpur, yeah. Okay.
It is Bharatpur, sir, but still Kathmandu, it is not available. We have to wait to come this implant at least 3-4 months, sir.
Okay. But plate fixation has been very well described. Whenever you do a subtrochanteric osteotomy, and suppose your stem fixation, you are not sure about the rigidity of fixation, you can always add on a stem. And number two, the excised bone, whatever you have excised, you can put it there as a graft locally rather than throwing it away. And many times surgeons also, we put, rather than putting a plate, we put the graft all around the osteotomy site and do a surplus wearing. So that graft is in place and it provides additional support, cortical support. We split the graft, whatever segment of bone you have taken out, you split it and put it on either side and do a surplus wearing.
Yes, sir.
So that helps.
I have first tried to wrap the osteotomy side by that osteotomized bone by fracturing, making these two part. But still, I am not confident enough that it will hold on. It will not prevent any rotation. So I removed it. I put the bone graft in cancellous bone graft from the head part all around the osteotomy site and protected it with plates, sir.
Yeah. Now, with the coral stem, of course, you have to put a plate. And rightly you have done that.
What are the
So that
size
is
of the
fine.
stem here? It must be the smallest size, right?
Smallest size is
Which
Smallest.
one? Size 8 or size 6?
it is size 8, sir. It is
Size 8, yeah.
size
Yeah.
8.
Once the smallest coral stem which is available is size 6, but one has to be very careful in putting size 6. It is not recommended to put if the weight of the patient is more than 60-70 kilo, then prefer avoiding using size 6 stem. It's a very thin stem, especially designed as a dysplastic stem. Now, how did you locate the acetabulum? With the Shyam or
With the Shyam, yes, sir. With the,
yeah.
all the elongated capsule, thickened fibrous soft tissue structure, all are covering the whole of the acetabular side, and I couldn't reach the acetabulum directly, so I used the Shyam, sir.
Yeah. And this is one of the condition where you have to do a adductor tenotomy before giving the positioning.
Yes, sir. I did the percutaneous adductor tenotomy, sir.
Yeah, then for the benefit of the viewers, I'm just telling, usually you do adductor tenotomy after the surgery if it is tight because of adduction deformity. But this is one of the conditions because it's a congenital and you have to release it before surgery so that intraoperatively, except the abductors, you release everything from the proximal part of the femur in order to bring the center of rotation down. That is the thing. And how did you decide about the inclination of the cup? Inclination and version of the cup.
Is so intraoperatively while intraoperatively inclination curve version is I have already planned in X-rays or out X-rays are already preoperative X-ray.
So planning is extremely important here in
Yes,
this
sir.
kind of
I've
cases.
already planned, sir. Inevitably, if any mistake can arise because of this, no acetabulum actually native side. So I go all during the operative procedure under CM guidance, sir. Everything was prepared prior to operation in pre-planning. Still, I was in doubt, so I did it in under CM guidance during the while dreaming, sir.
Anytime you have used a cemented stem in these kind of cases for everybody, Arun, Deepak, have you used a cemented stem? Writington people have shown very good outcome with a cemented stem also in this plastic situation.
Yes, sir. I have not seen or used a cemented stem in this situation. No, sir. Yeah, I have also, seen the reports, not seen it being done, or I have not done it myself.
Yeah.
No, sir. Now we got the privilege of ashram, so we are
Yeah, that is the thing. Yeah, we get ashram. Cemented stem also we keep standby. Sometimes, cemented stem, you can adjust the vertical offset. You can reduce the vertical offset, and maybe if it is a little borderline crow 3, crow 4, then you can just put a cemented stem. So without doing osteotomy, you can reduce the hip and accept little high center of rotation. That is the thing. And cemented stem. Writington, they have shown very good outcome with the cemented stem also in Exeter group with this plastic hip.
The other thing was, how was the femoral version, Manoj? So I think that is another thing that we lose control of, or we cannot control when we put in a metaphyseal fitting stem. So how was the femoral version in this case?
Manoj, how do you decide the femoral version here? Actually, the smallest size, in what direction it goes, you have to accept that, I think.
Yes.
Very
Yeah,
difficult.
that is the problem with using a metaphyseal fitting.
After doing the transverse test, subtrochanteric osteotomy, I just first want to feed the stem within the canal, sir. Then there is no any gap after fitting of the implant into the canal stem. So actually that there is no any proximal femoral deformity also, any angulation deformity also, and the canal is simply narrowed, and narrowed. So it do not any disturb for producing the native femoral version while doing this case first, because I have fully focused on whether the implant will dislodge or not, whether any gap created or not, and whether I can get.
Yeah, it is difficult to control version with a coral type of stem. That is why SRAM stem, you know, you can adjust the length, version, everything, and or a Wagner stem, which is a tapered conical stem where you can adjust the version also. But with the available resources, I think you have done the best job.
Austere environment.
Okay. Yeah, any other question, or we move to the next case?
The last case.
Okay. So, Dr. Manoj, can you just stop sharing your screen? Thank you so much for presenting this case all the way from Nepal, and we are really, you know, grateful to you. And Dr. Arun also, we are grateful to you for generating discussions.
Thank you.
Could you stop sharing? Yeah. Also, let us move on to last case related to musculoskeletal oncology. So we have Dr. Nitish, Jagdish, Jyoti today to present a case related to musculoskeletal oncology. And Dr. Nitish is a MBBS from Jipmer, Pondicherry, and MS Orthopaedics from Postgraduate Institute of Medical Sciences from Chandigarh, and currently pursuing his senior residence at All India Institute of Medical Sciences, New Delhi. Welcome, Dr. Nitish, and thank you for joining today for sharing your case.
Thank you, sir.
And we have Dr. Jagandeep Singh Virk to moderate the session on musculoskeletal oncology. Dr. Jagandeep is a consultant in orthopedic oncology at Paras Hospital, Panchkula, Haryana. He completed his AO trauma fellowship from Singapore General Hospital, Singapore, and musculoskeletal oncology fellowship from RGC ARC, New Delhi. He was also a clinical trainee at Tata Memorial Hospital, Mumbai, and as a fellow in ortho-oncology and robotic joint replacement surgery at Macquarie Park Hospital, Singapore. Thank you, Dr. Virk, for joining today and devoting your time towards academics.
Thank you.
I'll stop sharing the screen, and now I welcome Dr. Nitish to share his screen and present his case.
Yes. Yes, sir. So I'll be presenting fungating back mass that we had operated 7 months ago in our oncology unit. Basically, as you can see, it was a 50-year-old male, a resident of Delhi. He was a plumber by occupation. He presented to us with this large fungating mass in his upper back region on the left side. It was he has had this swelling for the past 10 years, which was initially just pain and small swellings. But in the last 6 months, he developed this rapid growth associated with ulceration, associated with bleeding, and also purulent discharge. To discuss his brief history, he initially had 3 small swellings in his left upper back region, and this onset was around 10 years ago, where he had gradually progressing. It was actually a slow progressing history, and he only had occasional dull pain. So in the beginning, he had sought treatment from a private setup elsewhere, and they had planned excision, and they had taken him up, and during the surgery they had to abandon midway because there was excessive bleeding associated with the surgery. So with whatever excision that was possible, they had done, and they had followed him up, and he was the diagnosis was, I mean, he was informed that it was a malignant tumor, and then he was following up with them, but he was never planned for a repeat surgery again. And over the next 10 years, it was slowly growing. And in the last 1 year, he experienced sudden increase in the size. And in the last 6 months, especially, he had ulceration, bleeding, and pus discharge, and with on and off episodes of fever. He had no pressure symptoms due to this swelling. There was no breathlessness, no chest pain, and there was no neurological deficit. It was quite close to the spine, but he had no deficit in his lower limb or the upper limb. and there were no other swellings elsewhere. And functional disability, that's another catch here, because 10 years he has had this, and it never really bothered him, neither cosmetically nor symptomatically. So he was satisfied with his activities. And in the last 6 months, especially because of the ulceration, he was quite worried, he was quite bothered, and it interfered with his daily activities. And on examination, you can see this was quite a large swelling, around 30 cross 20 centimeters in the left upper back region, especially in the, it was, to be precise, it was in the interscapular region, more towards the left side. And proximally, it was almost corresponding to the scapular spine on the left, and distally, it was beyond the inferior angle of the left scapula. And it was crossing midline, and it was around 5 centimeters from the medial border of the right scapula. And it was displacing the left-sided scapula. And it was locally warm. There was tenderness on deep palpation. As you can see, there were two ulcers, one cephaloid, which was around 7 cross 5 centimeters, and one at the caudal lateral aspect, which was 15 cross 5. And the skin was indurated, tethered, and it was hyperpigmented. It was bony hard in consistency with variegated nature, and it was immobile. And on inspiration and expiration, the mass was mobile. So it was an indirect evidence that it was probably a chest wall tumor. And again, like I said, clinically also, and on examination, there was no neurovascular deficit. There were no visible pulsations. So that ruled out the possibility of any hemangioma. And while all this happened, basically the patient presented to us in the month of October last year. And in the last 1 year, when he was really bothered by this, he was initially visiting the oncologists, the medical and surgical oncologists, and the chest physicians and the cardiothoracic surgeons. So when he had come to us, this was the condition. This was the chest radiograph. As you can see, sorry, there is no another orthogonal view. And on this AP projection, you can see it appears to be a chest wall disease, and there is a large exophytic soft tissue element. And you can't really make out if the chest condition is poor here, or is it purely a chondroid tumor because of all the flocculations and the matrix mineralization that you can appreciate. So we decided to get a CT done, where on the left you can appreciate that the epicenter appears to be from the left-sided ribs, with a large exophytic mass with multiple chondroid calcifications that are quite appreciable here. And on the right, you can appreciate that there is a subpleural nodule. If you can appreciate that. So it was not only a primary malignancy of the rib with exophytic tissue, exophytic component, but also there was a lung nodule. And then we confirmed it with our radiologists, and the extent was from the level of T3 to T10. There was also an intrathoracic extension. There was lung nodule. We got an MRI done. This again, you can appreciate that appreciate the extent from T3 to T10, and the tumor appears to be arising from the 6 and 7 ribs with a large exophytic element, and also leading up to the skin with ulceration. And this is the axial section of the MRI. Again, you can appreciate multiple nodules in the left lung, and also the subpleural nodule and the intrathoracic extension of this mass. There was also a staging and a metastatic workup done. This was compared with the previous PET scan that was done in 2022. There was a clear evidence of increase in his lesions, increase in the activity, and also there was metastatic evidence in lungs and also his left-sided axilla. So now it had probably transformed from a low-grade to a high-grade chondroid malignancy. And all this while the surgical oncologists deferred any surgical intervention, medical oncologists had advised, and he was put on pazopanib for around 8 to 10 months. So the intention was to prevent further growth, to prevent the angiogenesis, so that the growth can be hindered with. But however, he did not respond to that efficiently. He had progressive increase in swelling, progressive ulceration, progressive bleeding. And however, because of the metastatic nature and the current status, the intent was purely palliative, both from the oncologist side and also from our side when he was referred to us. So we had, following all this workup and planning, we had planned to proceed with the wide excision. And this was our setup. The patient was positioned in prone with all the necessary pre-anesthetic preparation, central line and arterial line and ICU backup. And this was our utilitarian incision, as you can appreciate it, from the nape of the neck extending down to the left-sided iliac region. And this was following excision. Basically, we proceeded with a wide excision of the mass, and we debrided all the tissue underneath. We had to sacrifice the rhomboids, we had to sacrifice the erector spinae, and you can see the defect there. That was the region of the pleura and the intrathoracic space. So we had chest surgeons, general surgeons in the chest unit. They were available there for us, and they helped us in dissecting out the ribs. The posterior part of ribs were excised, achieving negative margins there. And the pleural defect that was created was repaired primarily by the surgeon, and also an intercostal drain was placed. And as you can see, beneath was the latissimus dorsi. Along the anterior and posterior borders, we continued our dissection and we mobilized it, and we could achieve the soft tissue coverage of the pleural space. However, the skin could not be covered primarily, so we had just put him on a vacuum-assisted closure dressing. This was the excised specimen. As you can see on the left side top part, you can see the excised ribs, and the lower part shows the chondroid matrix myxoid stroma. And this is the dorsal aspect of the swelling. And histopathology came out to be a high-grade chondrosarcoma, as we had suspected and we believed. And out of the two ribs that we had excised, one of the ribs showed the presence of the tumor. And this was the immediate post-op X-ray. On the left side, as you can see, following excision, we had kept him on VAC. That white structure that you can see, that was the vacuum-assisted closure suction tube. And the chest drain, you can see the tubing on the right top. The issue was he was transferred to ICU. He was kept on triple inotropes, and all were on suboptimal doses. He was really, really sick, and he was intubated overnight. And there was almost 1.5 to 2 liter blood loss even after the chest drain and vacuum assisted dressing was done. So he was continuously requiring blood supplements, blood transfusion. So massive transfusion was already ongoing. He had already received 10 units intraoperatively. And immediately we decided to take off the vac dressing and explore the wound locally. We found there was no active bleed, active ooze. So we just kept him on paraffin dressing. And this was the first dressing that we saw on day 2. And day 1, there was no slough. This was day 2, where you could see there was some necrotic slough on the muscular coverage. There was some superficial epidermal necrosis in the midline. So we decided to take some wound cultures, and we also assessed his X-rays serially. As you can see on the left, it was first week of December, and on the right, it was second week. You can see his chest was progressively deteriorating. He was developing opacities on his left-sided chest. There was pleural effusion on the left side. He had continuous output in his chest drain. And to add to our problems, we picked CRAB, that was carbapenem resistant Acinetobacter baumannii. So we consulted our infectious diseases specialists. Previously in the ICU, he was already started on meropenem. And following this, because he was resistant to everything except colistin and tigecycline, they decided to put him on polymyxin and linezolid. And we took him up for a surgical debridement. This was first debridement that we had scheduled in the first week of December. And we had debrided the necrotic tissue. We had cleared all the slough. We had given a thorough lavage, and we put him on VAC dressing. And this was the appearance on serial VAC applications bedside, where locally the wound dressing was done and the VAC dressing was applied. And over the period of 1 month, you can see the wound was granulating really well. There was no dead space. His chest drain output was minimal, and once it was less than 50 ml, we decided to remove the drain, both the chest as well as the surgical drain. And at the end of December, you could see his chest. However, clinically, he still had persistent cough with expectoration. There were no fever. There were no fever episodes. His chest was improving, but there were some opacities which were still persistent. So we had planned him for split thickness skin grafting, but because of poor chest, the anesthesia team never deemed him to be fit for surgery. And this was in the month of January. So we had kept him under admission. He was still on IV antibiotics. His chest condition was improving. He was mobilizing well. He had resumed all his in-bed mobilization as well as out of his bed. And in the month of January, we decided to put him on oral antibiotics, and we decided to discharge him and bring him back when his chest condition improves and when the anesthesia team feels he's fit for surgery. But in the month of January and February, when we had kept him on serial follow-up, and we could see that his wound was doing really well, and there was peripheral healing by secondary intention, and the patient was also quite reluctant to get another surgery done. He had resumed his activities. He was working as a plumber, and he was quite satisfied. He just wanted to continue follow-ups, and was attending our outpatient clinic and undergoing regular dressings with paraffin gauze, and this was his improvement. And as you can see, in the month of March, then May and April, it has completely healed by secondary intention. Now he is able to do all his activities. He doesn't require any more dressings. He never had to undergo another surgery. And this was his latest X-ray. You can see his chest has also completely cleared. There are no opacities. There's no effusion. He has no breathlessness. And this was his last visit to us. So what I'd like to convey to our viewers today is it is imperative to consider palliative debulking surgery in such morbid patients especially when you have such good multidisciplinary assistance, thanks to our intensivists, thanks to our infectious diseases specialists, and especially in the current era with all the innovation we have, I think palliative surgery should always be given importance. It should not be overlooked. And it especially you contribute significantly to the quality of life of the patient as well as their family members. And I would also like to quote this. I found this in this article regarding fungating malignancies. As surgeons, we should we always strive for a tangible cure, but we should also focus on providing palliative resection so that death with dignity is enabled, and that is a very important service, as you can see. So I'd like to conclude my presentation.
Thank you. Thank you, Nitish. That was an excellent case, and with a good positive outcome of a very difficult and complicated case. Thank you for presenting it. And did you put any post-operative anything else? This chondrosarcomas are of course radio resistant.
Yes,
any
sir.
of these?
No, sir. He was, because his was
medications?
high-grade conventional sarcoma, chondrosarcoma. We had consulted the pathologist also. He was neither sensitive to chemotherapy nor radiotherapy, and currently also he still has those lung nodules. So he has been scheduled for his PET in the next month. So we will see if they are resectable, what is the extent of the lesion, how many nodules he has. If they are resectable, then we'll have to consult the chest surgeons again, or else we'll have to keep him on close follow-up. I mean, because he was neither sensitive for chemo nor radiation.
Okay. Yeah, over to Dr. Virk, please, for your opinion on. You have to unmute yourself.
Sorry, just the power went out. Actually, there's a big storm
Oh,
here
I
in
see.
India. So the power got out. Although I saw the entire case, I have rejoined back on my mobile now, actually. I was on the laptop earlier. So, a well-presented case, Nitish. Obviously, a Herculean task to manage a fungating chondrosarcoma, and obviously metastatic at presentation, and a palliative intent of treatment was offered to the patient. It is important to offer a palliative treatment to such patients. I agree with your concluding point. I would just like to ask a couple of questions, Nitish.
Yes, sir.
One is that did you have any previous histopathology reports, and did you repeat a biopsy before?
Yes, sir. Yes, sir. Actually, the records which dated back to 10 years ago, they were not available. And prior to presentation to orthopedics clinic, he was being followed up in the oncology unit. So they had already gotten a fresh biopsy done, and that had proven to be high-grade chondrosarcoma. So with that biopsy, we had planned the surgery after all the necessary workup. So we had a biopsy, we had a diagnosis in mind.
Okay. And the second question I want to ask, Nitish, is that did you plan preoperatively for giving the patient maybe a local advancement or a rotational flap or something for
No,
soft
sir,
tissue
actually.
coverage?
Yes, sir. Yes, sir.
Did you plan any giving a soft tissue coverage to the patient, maybe in the form of a flap, maybe involve the plastic surgery team?
Sir, primarily we had consulted the plastic surgeons for possible intra-op assistance for any local coverage. Actually, because the extent was quite large and there was significant ulceration with purulent discharge, so there was no intention to proceed with definitive coverage in the first surgery. So our plan was to proceed with the excision, and reduce the raw area to whatever extent possible and put him on VAC dressing. And then subsequently, over the next few days, when his clinical condition improved, we had planned a definitive coverage in the form of flap or graft or whatever deemed fit.
Okay. And lastly, I would like to ask that how do you follow up these chondrosarcoma patients? What is the protocol that you follow and what all investigations you usually get done on the follow-up of these patients?
Sir, routinely from this perspective or in general, any chondrosarcomas?
In general, for sarcoma patients, be it
Sir,
chondro.
usually in the very first year, first 6 months, we keep the patient on a 3-weekly follow-up followed by 6-weekly follow-up. Then after 6 months, we keep him on a 3-monthly follow-up in the first year. And in the next 2 years, he's kept on a 6-monthly follow-up. And after that, every yearly for the next 15 years. Actually, chondrosarcomas, usually they're above 40-50 years of age, and their life expectancy in higher grades is around 50%. 5 years. 5-year survival is 50%. So any patient who is surviving 5 years and beyond is a survivor, especially in chondrosarcomas. So after 2 years, a yearly visit will suffice. And in this patient, because it is his first half of his year, he is visiting us almost every 3 monthly. Now it's 3 monthly. He was visiting us almost 6 weekly, sir.
What investigations you do during each follow-up?
Sir, first clinically we inspect his surgical site, because usually we pick up some soft tissue nodules. Soft tissue recurrences are quite common, be it any sarcoma. So we clinically inspect the patient on every visit. We look for any soft tissue nodules, any local recurrence. If suspicious, we get an ultrasound done with the expertise of our radiologists. And if beyond that, if there is any suspicion, then we get an MRI done in addition to the normal imaging. Otherwise, we get a simple X-ray on every visit, and MRI if there is any suspicion, and 6-monthly PET in case of metastatic diseases, and also to look at any residual or recurrent in the primary site.
Any other questions? So
I think so. It was a well-managed case. Obviously, that it has to be a multidisciplinary approach when we are undertaking such kind of surgeries. We have to involve the plastic team, the lung surgeon, the general surgeons, and a well-managed case at the end. And it is more of an institutional practice where, they also kept the patient for a prolonged admission. So that also needs to be highlighted in this. So a well-managed case in the end, sir.
Yeah. Arun, any question?
No, sir. I think I had one question. I think it has been already answered. I mean, about the rotation flap or coverage in the primary, but I think he has already answered.
Yeah. Deepak, you have anything to add?
No, sir. It's well explained by himself in its comprehensive slides. It's all explained.
Yeah. So every step of the case and follow-up of this case has been so nicely presented. Thank you, Nitish, for that excellent case, and really enjoyed your presentation.
Thank you, sir. Thank you for this opportunity.
Could you stop sharing your screen? Yeah, so we had 3 excellent presentations today, and all 3 were very well managed, and we had also a lot of discussions which are generated. We thank all the 3 orthopedic surgeons for presenting the case, and all the 3 mentors also for being there and discussing about these cases. We'll again meet after 2 weeks with again new subspecialties. Now over to Deepak to give concluding remarks.
Thank you all. Thanks to all the speakers, and special thanks to the mentors and the expert panel who devoted their time this evening. We'll be back again after 2 weeks with new subspecialty in spine, pediatric orthopedics and trauma on 19th of June. Thank you all. Good evening.
Bye-bye. Have a nice evening.
Thank you, sir.
Poonam, you can stop the live.